Welcome to Therapist Uncensored, a podcast where therapists freely speak their minds about real-life matters.
Hi, welcome back to Therapist Uncensored. We're really excited by our guest today. We are always looking for fresh new voices and the latest and greatest when it comes to theory and ideas on the relational sciences and attachment. And in that vein, we discovered a book that really knocked our socks off. Dr. Daniel Brown and Dr. David Elliott, along with a host of amazing contributors, wrote a book that we think stands out among the rest related to attachment. It's entitled Attachment Disturbances in Adults, Treatment for Comprehensive Repair. It was published in 2016, so it's fresh off the presses pretty much. And we're really excited to have Dr. David Elliott on our show today, and I think you're really going to appreciate what he has to say, and you're going to appreciate listening to Sue. Sue's not easily impressed, and you're going to hear that she really kind of geeks out on this one, so I think you guys are really going to enjoy it. But before we get started, let me tell you a little bit about Dr. Elliott. Dr. Elliott graduated from Harvard University, and he trained at Tufts University Counseling Center and McLean Hospital, and he is currently on the faculty at the International School for Psychotherapist, Counseling, and Group Leadership in St. Petersburg, Russia. And he is also in private practice here in the United States. So without further ado, let me turn it over to Sue.
Let you introduce yourself.
Hello, Sue, and hello, everybody. Thank you so much for having me on your show. I'm primarily a clinician. I'm a psychologist, been in practice since 1990. And my practice is based in Providence, Rhode Island. And I actually decided to become a psychologist when I was 12 years old. So I've stayed true to that and have been very happy about that choice. And my understanding of why I decided so early to be a psychologist is that I was a very, very shy, very sensitive, and probably insecure kid. And I could really identify with people who I read about as having difficulties with their feelings. So I got more interested in that and actually came into this profession and have found it to be tremendously rewarding in all sorts of ways.
That's so true. So many of us got into this field for similar reasons, and it's just a matter of whether we are conscious of that or not.
Yeah. So, in addition to having, been quite shy and sensitive, I was also quite mentally identified. I got lots of reward for doing well in school, and some of my identity formed around that.
So why don't you start by telling us why attachment? What is this book must have really taken, quite a lot of work. So why put your heart into attachment specifically? One
of the foundations of my interest in this was just my own experience of attachment in my history and working with that over the years. But in addition to that, several things. One, when I came to recognize, both through my practice, my psychotherapy practice, and just reading the research, the pervasiveness or the high prevalence of insecure attachment, I just felt like it's just clear. It is clear to so many people now in the field how important this topic is. If it's true, as estimated, roughly 40% of the population of Western countries has insecure attachment. That's a lot of people. And when somebody has insecure attachment, and of course there can be a wide range of severity of that, from less problematic to very severely problematic and disruptive, but wherever someone would fall along the spectrum of attachment insecurity, they're likely to have difficulties in a number of areas that really affect well-being. For example, self-development. Insecure attachment interferes with the development of self-esteem, with stability and clarity of a sense of self, with organization of mind. And, those can create real problems in people's experience. Obviously, attachment difficulty can contribute significantly to relational disturbance, difficulty with intimacy. People can really want to be close with people, but have a pattern of relationships that last, 6 months at a time or 1 year or less and be really frustrated with that, or just avoid relationships altogether and either conscious or less conscious levels be quite unhappy with that.
So can I ask you a quick question? So you said 40% insecure, but what do you think about that actually even being, because you said Western society, and if I'm remembering correctly, isn't that like when I think of the Crittenden work, when you begin to look cross-culturally and when you look at more clinical populations and things like that, isn't that 40% even considered, like that's more of the non-clinical kind of Anglo-white?
Yes, exactly. General population.
General pop.
And when you do start looking at other groups, other cultures, other countries, clinical populations, the numbers get more frightening. So, for example, there have been several studies done looking at the attachment status of people with borderline personality disorder, and approximately both studies found that well over 80% of the people had, with borderline personality had insecure attachment. Looking cross-culturally, there was a study that was published in 2010 looking at infants in St. Petersburg, Russia. And this study used the Pat Crittenden's assessment methods and classification system. And according to that, their methods found that only roughly 8% of the infants had secure attachment. 92% had insecure attachment. I teach this material regularly in Russia, in St. Petersburg, and I was actually teaching a seminar when one of the people in the group told me of this study, and I didn't believe it. I thought, how can that be? That must be, an error in the numbers that you're reporting. And I could see people in the room, indicating or nodding their heads when those numbers were repeated, saying, no, we understand that. These numbers are accurate. We believe that based on their own experience. So yeah, this is a worldwide challenge. And if we're interested not just at, helping people individually to lead better and better lives, more comfortable, more fulfilling lives, but also interested in larger social issues, then I think this is a very important topic to understand and to try to bring remedies.
Right. I do too, and that's one of the things that to me is really exciting about talking about the more recent work, because when we talk about security, a lot of the factors related to security really are things like, there's something that I read that if you have, say, 9 of these things, and it was things like if you are married, if you have a good job, and it was basically, as you have these things that are predictors of secure attachment, they, of course, are things that take you out of high-risk categories. And then as you have high-risk circumstances related to socioeconomics or what have you, you move out, you have a greater chance of having some of these insecure categories or anxious insecure categories. Yes. It's an important cultural conversation to be having, and then to be creating these interventions. And this is where I definitely want to steer us towards some of the things that you have learned and what we can do about it. These very incredible assessments that we've had for decades now, and the research, what has all of this taught us about how we can intervene.
Let me just say a couple more things briefly about
Sure.
I think the importance of this topic too. Another area of functioning that is problematic when there's insecure attachment is emotional development and emotion regulation. So people who have insecure attachment will tend to either over-regulate emotions, like kind of shut down and, say, I don't feel, I'm a rock, stay away from emotions. That would be more the dismissing pattern. Or will tend to be overwhelmed by emotions, have very difficulty regulating emotional experience and tend to get confused and disorganized and overwhelmed and lose perspective. That would be somebody with anxious preoccupied attachment or disorganized attachment. So when we find that as we treat the attachment difficulty, there's greater internal organization and greater emotion regulation capacity. And, that in and of itself brings more well-being to someone's experience. They're not so scared of emotions, not so overwhelmed by emotions. And also, if they haven't felt emotions very much, able to feel something safely and more comfortably. So that's a really positive thing. And then the other thing I wanted to say is that through my work, in our work, those of us who are involved in writing this book, in our work with people who've been traumatized in some way, who are coming to us with post-traumatic conditions of various sorts. We find that some people do very, very well with more traditional trauma processing model of trauma treatment. It's more of a cognitive processing approach. Pat Risick and her methods are tremendously valuable. Pat Risick, R-E-S-I-C-K, or R-E-S-I-K, I don't remember the actual spelling, but we find too that some people, if you try to apply that method, they become more disorganized, more overwhelmed, and actually the symptoms get worse. Mm-hmm. And what we found is that those people who have that kind of experience are people who have an underlying attachment disturbance that has led to difficult emotion regulation and poor internal structure of mind or organization of mind, so that when they start to look at the traumatic experience as part of treatment, they don't have the emotion regulation skills or the internal organization to help them manage that experience. They get overwhelmed. And so what we find is that for people with complex trauma particularly, or people we see aren't doing well with some of the more traditional trauma treatment approach, if we treat the attachment difficulties first, then often not only does the emotion regulation skill develop and the internal organization and structure of mind develop, but the trauma itself might resolve just through the development of those internal capacities. The post-traumatic condition might resolve. And then for those people for whom it doesn't resolve through the attachment work, then it's possible to go to the cognitive processing approach for trauma treatment in ways that can be very efficient, and the person doesn't get overwhelmed by it and notices gains quite quickly.
And that makes perfect sense, because in treating the attachment, you are caring for sort of this young self in such loving, supportive, attuned ways that haven't been done before. So that, in a sense, is treating the trauma potentially. Yeah. Like it really is filling, like it is directly treating the trauma frequently. So it makes sense that the trauma itself would be healing in many cases, and maybe not all, but that it's a double dose in a way. And then even if there is a specific trauma that doesn't get touched by that attachment healing, having that secure base to then stand on, to then do the trauma work in a more regulated way is just a good thing. I mean, I really do understand what you're saying, that if you get to the trauma and you get dysregulated, but you don't have a floor, if you don't have a foundation to stand on, then you're not doing anybody any favors. As a matter of fact, it can be re-traumatizing.
Re-traumatizing, yes. We don't want to do that.
I really appreciate what you're saying. It makes a lot of sense. And it would be an easy mistake to make. It would be an easy mistake to make, because so many times the client would come in with that's what's knocking under the hood. That's what they want help with, is the intrusions or the nightmares because that's the thing that's easier to point to than the attachment difficulties. So that would be the easier thing for the therapist to feel like they're being helpful about. I could just see how that would be an easy mistake to make. I'm sorry, go ahead.
Yeah. No, I really like how you're phrasing this as well. And it's so very important. And we're hoping and looking forward to more research coming out about this as well, in terms of the these trauma patterns and the attachment and trauma and the treatment approach that we've just talked about really lends itself to empirical exploration. So we're really hoping that we'll be able to produce some data at some point before too long. Just one thing more I wanted to say is an acknowledgement of the other people involved in this book. Daniel Brown is the senior author of this book. It's Brown and Elliott. He's a psychologist based in Boston who's a brilliant scholar and clinician, and he's been a pioneer in trauma treatment and understanding of trauma and memory, and also on hypnosis and hypnotherapy, and also on meditation and mind development in the Tibetan Buddhist tradition. He leads a lot of retreats all over the world now that focus on helping people realize who we really are, helping us realize who we really are in terms of beyond the personality and beyond our personal identities. So he's a very integrative thinker, has integrated the whole spectrum of human development in the way he he does his work, and I feel very fortunate to have been working with him in creating this book. There are also 7 other people who are listed in the book as contributing authors, and these are other people who we've all been part of an ongoing study group for the last almost 10 years, I would say, where the ideas that we present in the book were developed and refined. So I just want to acknowledge that this has been a group effort that has been very rewarding for all of us.
Creativity coming out of a group like that is just so amazing. And so what to do about this? What's the intervention? What's the high level, what are some of the practicals? If there's just a way to just begin to sketch out the general ideas and to kind of get people hungry to learn a little more and, give us an idea of the direction that you're beginning to think related to treatment. And I can share, I've begun to use this in my practice, and it has been practice changing. It really has. So go ahead.
When we looked at the field of treatment of attachment, we recognized that there developed 3 primary approaches to helping people with attachment difficulties. And the most common and the longest existing developed actually starting from Bowlby. And that approach involves the ways that the therapist is with a patient that helps the patient to develop a new internal working model of attachment. The idea is that the therapist becomes a good attachment figure for the patient who did not have good attachment figures as a child, and because of that had developed insecure internal representations or internal working models of attachment. So the principle is that through the therapist behaving as a good attachment figure, the patient will have a new positive experience of relationship that gets internalized and replaces the old negative or problematic internal representation of attachment. So that's been a foundation in the field of treatment of attachment, and there's a lot of merit to that. But we also saw some limitations in that, which I'll get to in a moment. The other area, or a second area that has emerged more recently in the last, probably in the last 20 years, is the development of metacognition. Peter Fonagy and his colleagues and others, Anthony Bateman, John Allen, also a group of Italian psychologists from the Rome Institute for Cognitive Psychotherapy, or the Third Center for Cognitive Psychotherapy in Rome. They have focused on helping people develop metacognitive skills. And metacognition is essentially the capacity to be aware of one's own and others' mind and mental activity as mind and mental activity. So it's knowing that what's in the mind is in the mind. And it's essentially like observing ego, going all the way back to Freud, talking about, the development of the observing capacity. But it's been highly refined since then. And Peter Fonagy and his colleagues developed a whole treatment called mentalization-based treatment that was talked about in the last podcast, as you said. And because problems in mentalization and problems in metacognitive ability are very present in people with insecure attachment, the notion is that if mentalization, metacognitive ability can be enhanced in people with insecure attachment, then that can help to reduce the attachment insecurity. And there's some good research that supports aspects of this. We find it to be really essential in the field. We also feel that there's some limitations in the way that's been done so far, which again I'll get to in a moment. And the third area that's emerged even more recently is looking at intersubjectivity and particularly collaborative and cooperative ability in people. And it turns out that in people with insecure attachment, there tends to be difficulty being in collaboration, being in cooperative interaction with others, sharing a goal and working mutually toward a particular goal, for example, being interested in and open to others' contributions and offering one's own contributions, kind of going back and forth. And because of some of the early problematic experience between, a child who developed insecure attachment and the caregiver, as adults they have difficulty with collaborative or cooperative ability. And some interesting treatments have emerged that focus on this as well. Beatrice Beebe and Frank Lachman have done good work in that area. Giovanni Liatti from Italy has done a lot in this. And we feel that that's very, very helpful. So Again, some limitations in that. And so what we did with our work and what we present in the book is present an integration of these three areas and three aspects of treatment that we feel respects and honors the strengths that are out there in the field in these three areas, and also goes beyond the limitations as those areas have been and currently exist in the field. And we call these the three pillars of comprehensive attachment repair. First pillar is developing new positive internal working models of attachment. Second pillar is developing and enhancing a range of metacognitive skills. And the third is developing collaborative and cooperative ability so that the relationships can include that much more prominently. So these are the three pillars. And in our treatment approach, we engage each of these. We engage the patient or the client with each of these in various ways. And we feel that because each of these reflects a dimension of functioning that's known to be important for attachment security, if we work to enhance each of these, then the treatment can more effectively, more efficiently, and more comprehensively lead to earned secure attachment. So that's kind of a big overview. For developing positive attachment representations, positive internal working models to replace problematic insecure models, as I said, the general approach and the foundational approach in the attachment treatment has been the therapist behaves as a good attachment figure. And we think there's merit to that because at any age, we can internalize our experience of relationships. And if we have a very positive relationship, we will internalize the positive aspects of those, and that will bring benefit to us. But the problem, as it's been in the field, well, there are several problems. One is that in the typical psychotherapy context of a 50-minute session 1 or 2 times a week, the person meeting with the therapist who's behaving as a good attachment figure is not going to have a lot of experience, a lot of time with that person behaving in that way. So that we think is a real limitation. Secondly, as much as any therapist tries to be the best possible attachment figure, we're all human beings. We all have our own attachment dynamics. We all have our own limitations. And in those 50-minute sessions, it's a lot to expect that the therapist will always be fully on as the best possible attachment figure for any particular person to internalize experiences of. So that's the second limitation. And the third, and this is very, very important, is that in the therapeutic context of an adult patient with an adult therapist, that is developmentally and experientially very different than the formative conditions for the attachment bond, which is a child relating to an adult, a child relating to an adult caregiver or parent. So in a therapeutic setting, even if the therapist is a great attachment figure and the patient does internalize aspects of that experience with the therapist, it may actually not touch the problematic internal representation of the early experience because it's not an early experience. It's a current adult experience. So we don't think that the therapist as good attachment figure context really sufficiently approximates the formative conditions for the attachment bond and the representation of attachment.
Right. I like that a lot. It's like, no matter how great I am as a therapist,
right,
and even if somebody's seeing me a couple times a week or in group or what have you, the problem is, one of the problems is that the internal working model, it's a petri dish that we live with, and we're kind of souped in, it's our soup that we're immersed in, and we kind of don't even know that we are, it's almost like a DNA kind of like that we are thinking these things and generating these thoughts that are it's almost the unthought known of the old working model. It's the lens that we see the world. And so then we have this little parentheses of relief with a more secure way of relating, where that we get the attunement and all the good stuff that you get in therapy, hopefully. But all the rest of the time that we're generating this from this old internal working model. So yes, it can work over time, or even with a secure partner. That's good, and that does work, but that it's slow at best and perhaps
Right.
not enough. So this ideal parent figure protocol speeds up the process tremendously and is a much more direct intervention because the image is of the self as small and then the ideal parent figures. So it really hits the injury right on the nail on the head, and then it provides the missing nutrients like a IV. Like it really gives the exact nutrient necessary from an up-down perspective, not a peer perspective or anything like that. It's the parent. I'm curious, when you have used this with people, can you just give some examples of, like, do people typically use their parents and morph them into good parents, or do they use other things?
Great question. And let me just frame a little bit more the method itself, the ideal parent figure method. You know, as you referred to, we actually guide the patient to imagining himself or herself as a very young child. Actually, the first step is developing a very clear sense and experience of the body. So we enhance body-based awareness, body-based experience, which is consistent with how we experience ourselves when we're very young children. You know, the cognitive capacities, you know, when attachment representations form, roughly between 12 and 20 months, the cognitive system has not developed to the point of narrative sequences in thought. There's much more body-based experience. So we help the person become really kind of centrally focused in his or her body. And then we suggest that they imagine themselves being a very, very young child and support a felt sense of that, an actual felt sense of being a very young child. And when the person is able to do that and indicates that he or she, you know, has that sense, then we suggest that the person can imagine being with parents, but not the parents that they grew up with or any caregivers that they've known, but they can imagine now being with a new and different set of parents who are ideally suited to them and to their nature, to their needs, to their feelings. And then as a therapist, we co-create with the patient this imagery so that as a therapist, we set the frame saying, now notice the ways that these parents are being with you that help you feel so very secure, so very safe in your connection with them, for example. And so that's the frame. And we don't tell the patient, you know, what those qualities are. I mean, we can suggest those later. But initially, we ask the patient to just notice what he or she is noticing about his or her own imagined ideal parents that feels just right and that supports a sense of security. It's based on the principle that we, no matter what we've experienced, no matter how difficult, painful, traumatic our early experiences were, at some level, deep down, we know what we needed and we know what would be right for our healing and for our best self. And this method helps access that in people, and it can be so powerful and so beautiful and so moving when we experience this and help people come into contact with that. To answer your question specifically, often people will try to, will start to imagine their actual parents, but maybe behaving differently. And we gently guide them away from that, because even if they're imagining their actual parents who were problematic, behaving in not problematic ways, there's still a direct connection and association to whatever they experience with their actual parents, which can be problematic. So we say, we know your actual parents did the best they could, and this is not about rejecting them in any way, but now you have the opportunity, from what we're doing now, to just imagine if you had entirely new and different parents who could really be with you right now in all the ways that you would most need. And then we encourage the imagination. The imagination gives infinite possibility for the ways that these parents can be in positive ways. And going back to a limitation, the therapist as good attachment figure, we as therapists, we don't have an infinite capacity to be exactly the way that any particular patient needs. But the patient's imagination can create parent figures who can be just right. That's why we call it ideal parent figure method.
Right. I just was curious if you had because what I have found is if I can prompt them with some ideas, because at first they kind of flounder around, I can't think. And then when I give them a couple of ideas, I just see it when they get it, and it's just delightful. And then it's just usually their tear, you can just see it click.
Yeah.
And then it's fun, and it's like they can't wait to do it when it works. So I just was curious if you had found, like, I'm creating a list of things that people have come up with, and that's why I was just curious if you knew.
Well, what have you suggested? You said that when you make suggestions when someone's having difficulty.
One I'll share. Because these are active folks, I don't want to share ones that people have actually said, but I'll tell you one that I use that will get, because it's just one that I've generated, and that it does typically help people click, which is when people are struggling, I'll say, well, you can use anything. It can be a movie star or a whoever, and then I'll say, you could just think, until you can think of someone, think of the Obamas. People just love it because not everyone, you don't have to love the Obamas, but there's something about that couple figure that is just, people can at least temporarily park, and they can imagine warmth and pleasure and delight and safety and comfort and healthy boundaries if they've done something wrong. They can imagine being corrected and held and loved. And they might not stick there, but they get it. And it's also an up-down relationship, an authority relationship. So they can be little, and it often will kind of get it going. You know what I mean? And then it launches into who they might end up landing on. But it's just, it typically will get a knowing smile, I was like, oh, I get that. Yeah. Well, you've pointed them in the direction of what they're looking for, or what you're trying to help them find. So maybe I don't, I've botched the whole thing. I don't have the right idea. Maybe not at all. No. Maybe I've gone off in the wrong direction here. I don't know. No, I don't think you have. I think that, as you said, not everybody will immediately come up with these ideal parent figures. If they could, maybe they wouldn't need the treatment. Right, that's right. So often there is difficulty at first in coming up with these figures. There's a whole section in the book, in one of the chapters, of difficulties that a therapist can encounter with this approach, including the person having trouble coming up with parent figures. But one of the ways of responding to that is, just as you said, making some suggestions, like starting generally. Well, it could be someone from a movie or a book, or someone that you have experienced from the movie or book, or perhaps someone you've known who you've thought of as having qualities that you could imagine really loving in a parent, if you could have that in a parent, something like that. That's religious figures, or and we give some examples in the book, and someone had come up with, speaking of movie stars, Whoopi Goldberg was one ideal mother. And just like the Obamas, Whoopi Goldberg probably wouldn't be ideal for everybody. Right. What matters is each particular person's sense of ideal. Interestingly, one person used a family of skunks, that the parents were skunks. So sometimes people who have maybe some dismissing attachment or some difficulty with a sense of closeness, they might start with animals because that's a little bit safer. And as therapists, we just support that and support the relational experience with the animals. Over time, we keep suggesting ideal parent figures and gradually prompt toward developing more of a sense of a human ideal parent figure, and ultimately people are able to do that as well. So we set the frame and we attune to the patient and follow the patient's lead and co-create this imagery. It's a very dynamic process. Well, and what I love so much about it is that then it's just limited by one's imagination, and it's free, and people can do it all the time. And people have taken off and used their creativity to really play with it. And that's where it's just really, really been. And also the way that I have talked about it is, just like there's so much neuro research on, the use of imagery and, like the piano player that you can give a piece to and they can study it and not practice it, and then the person that practices it, and then that there's no difference just by using imagery. And people are familiar with that. And so it's sort of like that. This isn't for some people who think it's touchy-feely or too sweet or, you know, like a little la-la or something. My delivery tends to be more, you know, like this is very science-oriented. This isn't affirmations or super soft. This is actually hard science work. And it's really something you can actually do to create a new neural network that physically works and, you know, that will functionally help you gain all of those earn secure benefits.
Well, in terms of the, you know, the science of it and the sort of the developmental considerations of this, the imagery process through the ideal parent figure work, we're helping the person create internal representations. Mental imagery is an internal representation, and an internal working model is an internal representation. So we are actually engaging the psychological, neuropsychological process that's involved in the development of and maintenance of internal representations. That's very different than talking about attachment adult to adult, exploring behavior in one's current life with attachment patterns. That can be valuable, but as we said, it's just, we don't think it's efficient, and this is a much more developmentally and we'd say scientifically consistent approach.
Well, because you make the point in the book that it is pre-verbal, that if it's actual attachment, that all occurred pre-verbal, so that insight alone actually can be hurtful. And some of the attachment interventions can be hurtful and shaming because, we can point out, oh, that's dismissing, but that can just lead to a feeling of shame. We can become aware that I'm being dismissing, but insight doesn't necessarily help us change it. It can just make us self-conscious. And so that's part of why we really like to talk about it as a state, and it's changeable, and that's part of why I've been so crazy about the positive. And then I also like how you talk about these things being in the metacognition and also the collaboration. I love that too, because it's a really positive way to talk about resistance, and it's very non-shaming, and like talking to someone who might be in a dismissive state about their eye contact being down or their single word answers being a form of non-collaborative, verbal and nonverbal behavior, that it's a way, it's motivating, and it gives them something to do. Anyway, all of those things going together is part of what has been so inspiring and so exciting. And is part of why, for those of you all who have stuck with us, we are very excited to announce that we are working on, we're just in the final details of bringing David Elliott to Austin, Texas, so that he can present to us all in person for a comprehensive conference, and we can go into much more depth about this and hear much more from him. So, applause. If I had an applause meter, I would, yay! Yay!
Well, yes, I'm thrilled about that possibility. I love to bring this work to clinicians and to others, and in the attachment workshops that I do, I give people opportunity to not only present the methods and give a lot of detail about how to bring these into your practice, but give people opportunities to do the practice in the midst of the workshop in dyads, so that they can have some initial experience before leaving the workshop and get to talk about it and get to ask questions and to resolve any challenges that come up. So then it's actually easier to bring it into your office, once the workshop is over. And people just say very good things about that, being able to have that actual experience as well.
Do you have people do the experience on themselves or on each other?
No, we on each other.
I think that's great. I also think it might be great to do it on ourselves, but
well, certainly, yeah. There's, in as you referred to earlier, when we work with a patient and introduce this method to them, it's very helpful to encourage them to do it on their own as well, either making an audio recording that they can follow, or just more spontaneously calling upon the ideal parent figure imagery. I have patients come in and say, well, I was really kind of scared, before I was about to do this, but then I just had my ideal parent figures come, and they were very comforting and very soothing, and I didn't feel so scared anymore.
Yes.
Yeah. So that's an example of using it on ourselves. And
absolutely. I love that. I've even used it in my groups where sometimes people give themselves a hard time, I shouldn't have said that, and, that sort of thing, which is that's the old working model. And so it's like, why not, again, use this on yourself in a sense of the group can be the ideal. And I know this is a riff of what you're recommending, but I'm just sharing a riff of it, which is that if you're going to make something up, which that is a made-up experience that everyone's thinking these bad things about you, and this could be a party, it doesn't have to be group, right? But then make up the perfect response and make up the ideal response of what you actually need. And then the following week we can come in. So at least you're being held between times in the way that you need. And so that's been really interesting, and just as another way of working. And so, yeah, it's been very productive and generative. So
wonderful. I'm wondering if it might be helpful for your listeners, because I know there's a range. Some are therapists, some are not therapists. For me to go through one piece that's in the book, which is the 5 primary conditions that promote secure attachment. These are way back when Mary Ainsworth, as a close colleague of John Bowlby, started talking about and writing about maternal responsiveness, basically qualities of the mother, we would say now the caregiver, mother and or father, qualities that tended to support the child developing secure attachment. And over the years, many people have talked about, qualities that would be part of this category. But through all of our explorations and our work, we've come up with a list that we feel captures the essence of all that's been out there and really highlights the principles that parents can aspire to as they're raising their children, and that we as therapists can aspire to as we're working with our patients. So we talk about the 5 primary conditions that promote secure attachment. And the conditions involve, because attachment is a relational phenomenon, it involves both the experience of the child or the person doing the ideal parent figure imagery or the person in relationship, and also the parent or the caregiver or the therapist or the relationship partner. So there's, let's say, infant experience and then parental behavior that's designed to promote and support that infant experience. So the first thing that's really fundamental to attachment security is a felt sense of safety. So we want the child to feel safe in relationship, to feel safe in his or her own experience. And the parental behavior that ideally supports that, of course, is being consistently protective. The second is that ideally the infant, the child, will feel seen and known, will have a sense that his or her caregiver will be really attuned to his or her experience. So the parental behavior is attunement. The parent strives to be attuned to whatever the child is experiencing, to recognize when there's a change in facial expression and to know that that means that there's been a change in the internal state, and to be curious and interested and to notice that state, to let the child know that he or she has been seen in that experience. The third is that ideally the child will consistently feel comfortable. Of course, not 100% of the time, but that with the parent or the caregiver, more often than not, they'll be provided a sense of comfort. And the parental behavior that can support this is consistent soothing and reassurance. The fourth condition is the child feels valued, feels that he or she, as he or she is, not just by what he or she does, but his or her very being is valued. And that comes ideally from the parent or caregiver who consistently expresses delight, is delighted by all aspects of the child. Again, not 100% of the time, but maybe as I heard in one of your earlier podcasts, maybe 70% of the time. That more often than not, the parent is really delighted by who the child is. And then the last condition is the child feels supported for exploration, for discovering who he or she is at his or her best. And the parent supports that by encouraging inner and outer exploration, by showing interest in the child's inner experience, by allowing and reinforcing the child as he or she starts to explore through play, through moving away from the parent and finding something that is new and getting interested in that. So those are the 5 conditions that I think are relevant for parents who want to raise children to be as secure as possible, for therapists who, in the context of the imagery work and the 3 pillars work, want to be the best possible therapeutic caregivers, and even in relationships. These are relevant too. We see that relationships benefit from each partner being aware of the value of each of these conditions to support a strong and close relationship.
Well, so we're very excited. So everybody should stay tuned. And even if you are anywhere nearby, we would want you to come to Austin, Texas, meet us, come say hello, and come to the workshop. We are going to nail down some times. We'll, of course, let you know about it. But we are talking about partnering with some local organizations, and that's going to be very exciting as well. And we'll do some lead-up fun things, like maybe some reading groups, study groups, all kinds of activities that will be about this, but also just in general about continuing to deepen and learn related to the clinical relevance of helping people and deepening our understanding of attachment and growing security in the world, not just in Austin, Texas, of course, but across the globe, which is our point of this podcast. Can you share, if listeners would like to reach out to you directly, how best might they do that?
Probably the best way would be through my website, which is www.davidelliottphd.com. That's DAVIDELLIOTT PhD.com. So 2 L's and 2 T's in my name. DavidElliottPhD.com.
Well, you've been so generous with your time, and I know we are going to be in touch and planning this really incredible conference, we hope. So thank you very, very much. It's been a total pleasure, and I really appreciate all the inspiration clinically. And for all of our listeners, thank you so much for sticking with us. And please rate and review us on your favorite podcast player and sign up for our email list so that you do not miss a thing. We always send out, actually we don't email very often because we don't like to spam people or send unnecessary email. But when we do, we typically will pack it full of good, interesting, usable materials for you.
Sue, let me say too, I just want to thank you so much for, having me on and giving me the opportunity to talk about all this. And I, thank you and Anne and Patty for the podcast, the Therapist Uncensored podcast, which I think is just tremendous. And it's a real service to individuals and the world. Fantastic. I really appreciate what you're all doing.
Oh, that is awesome. Thank you. I really appreciate that. It's been a labor of love for sure. We've gotten some really sweet feedback from listeners. It's kind of weird sometimes to think they're actually somebody out there and we're not just doing a pretend hobby as 12-year-old kids, But sometimes that's how we kind of actually are able to do it. But it seems like it's actually really making a difference for some people. So we really...
I'm sure.
Yeah, it's really fun. But thank you. Okay. Really appreciate you saying that. And we'll be in touch. And so everybody, we'll see you around the bend. And thanks for listening.
Hi, I hope you all enjoyed the show today. This is the part where we have been experimenting with Ask a Therapist. And it has gone so well. We've gotten so many wonderful questions sent to us that we are going to do something different this time. We have received a bunch of questions in the cluster of 2 different areas. And what we've decided to do is to go ahead and instead of answering short, quick questions, we are going to do whole podcasts to answer and respond to those of you that have reached out. Specifically, we have a group of questions requesting information on disorganized attachment. So we are currently working on that as we speak. And then we've also got a segment of listeners asking us to talk about the therapeutic relationship, about the intense closeness that happens in the therapeutic relationship, as well as things that can happen that don't go so well, including maybe shame or abusiveness in the therapeutic hour. And so those are great questions, and we are working on a whole podcast coming in the future. In the meantime, I want to do a quick shout out to Hillary in Louisville, Kentucky, Helen in the UK, and Gary, Elizabeth, Marion, and Natalie, all from Texas. Thank you so much for your responses and feedback. We really appreciate it. Take care.
Therapist Uncensored is Ann Kelly, Patty Olwell, and Sue Marriott. This podcast is edited by Jack Anderson.